Before I begin, I'll just recognize, as the others have, that this presentation takes place on the backdrop of a global pandemic with a horrible virus. And I know many listening are on the front lines, putting themselves at risk to help others. And just want to say, I hope you're all healthy and your families are healthy and safe. And thank you for all that you're doing. I also now want to turn to the presentation. It's an honor to present these data on behalf of the executive and steering committee, the investigators, and most of all for the patients that volunteered for the study. These are the primary results of the Voyager PAD randomized clinical trial. These are my disclosures. The trial was funded by Bayer and Janssen. It's well recognized that more than 200 million people across the globe have lower extremity PAD, and they're at heightened risk of major adverse cardiovascular events. What has been recognized more recently on the left side of this slide is that those PAD patients that require revascularization are particularly high risk. Very early on after intervention, through the first couple of years, there's a very high risk of limb outcomes as well as MACE outcomes, and that risk profile continues long term. Even long after intervention, PAD patients that have had revascularization are at a fourfold risk of acute limb ischemia versus those that have never had revascularization, and they never return to the risk profile of a stable PAD patient. Now, if you're unfamiliar with acute limb ischemia, I'll turn your attention to the right side of the slide. This is the STEMI equivalent of the limb, where rapid reperfusion is necessary to prevent tissue loss. It's associated with long hospitalizations, a high inpatient mortality rate, the need for surgeries and long ICU stays. And at the end of all of this, about 15% are either dead or severely disabled and unable to return home. In spite of this risk, there are no proven antithrombotic strategies to reduce the risk of limb and cardiovascular outcomes after revascularization. The two randomized trials, large trials in this space, are shown on this slide in patients after bypass surgery on the left with the combination of aspirin and clopidogrel, or DAPT in the CASPER trial on the right with warfarin in the Dutch BOA trial. Neither of these strategies reduce risk. Both significantly increase bleeding, including warfarin on the right, increasing the risk of hemorrhagic stroke by almost 3.5-fold. This really highlights the vulnerability of this population, not only to ischemic outcomes, but bleeding outcomes. Voyager PAD was designed to address this gap. The objectives were to evaluate in PAD patients undergoing lower extremity revascularization for symptoms whether a strategy of rivaroxaban 2.5 milligrams twice daily added to low-dose aspirin would reduce major adverse limb and cardiovascular events versus aspirin alone, as well as to evaluate the safety of this strategy. Here is the trial design. Patients with symptomatic PAD after revascularization were all treated with low-dose aspirin. Clopidogrel was also used at the investigator's discretion. And on top of this, standard therapy was added, either rivaroxaban 2.5 milligrams twice daily or matching placebo, and patients were followed for a median of 28 months. The inclusion and exclusion criteria are shown here. Patients had to have PAD, including symptoms, imaging evidence, and hemodynamic evidence. But beyond that, there was no enrichment in this population for either adverse cardiovascular or limb risk. Patients were excluded if they were unstable or because of who they are, the drugs they had to take were at a high risk of bleeding. These are the outcomes. The primary outcome is listed at the top. This is a unique and a deliberately designed 5-point composite outcome for this population and in this setting. It combines irreversible harm events of the limb, heart, and brain, including acute limb ischemia, major amputation for a vascular cause, myocardial infarction, ischemic stroke, or cardiovascular death. There are secondary outcomes listed in the testing hierarchy below them. You'll note number 2 is a particular problem in this population, the need for unplanned index limb revascularization for ischemia. And number 4 is the combination of all-cause mortality as well as the other components of the primary endpoint. So event-free survival, essentially. Safety at the bottom, the principal safety outcome was to be major bleeding, purposely chosen due to the interventional setting of this trial. Secondary outcomes were ISTH and BARC bleeding. All outcomes were adjudicated by the CPC Clinical Research Clinical Events Committee. The trial was led by an executive committee, as shown here on this slide. The academic research organization that conducted the trial was CPC Clinical Research. The sponsors were Bayer and Janssen, and there was an independent data monitoring committee that monitored for safety led by John Dormady, who unfortunately passed away during the trial, and then afterwards Joshua Beckman. It was an international trial with a steering and national lead investigator committee, as shown on this slide, that led the trial. And it was a global trial with enrollment in North and South America, Europe, and Asia Pacific. Over 34 countries were represented. Here is the disposition. You can see patients were randomized in a one-to-one fashion. Drug discontinuation was around 14% per year, slightly higher in the rivaroxaban group. Withdrawal of consent was a less than 0.5% per year. There were 3 lost to follow-up in each arm. Vital status was known in over 99.5% of patients, and complete ascertainment of all of the primary efficacy and safety components was achieved in 98.8% of potential patient years of follow-up. Now I want to turn to the results. These are the baseline characteristics. Patients were 67 on median. 40% had diabetes. It was a sick population. More than a third were actively smoking. 11% was COPD. 1 in 5 had renal dysfunction by EGFR. Now, in spite of this risk profile, less than a third had known coronary disease, and only 11% had ever had an MI or a plaque rupture event. Background therapy is as listed. 51% got clopidogrel, 80% received statins, 2/3 received an ACE inhibitor or an angiotensin receptor blocker. The PAD and procedural characteristics are shown here. By design, patients were symptomatic. Over a third had a history of revascularization. The median ABI before intervention was 0.56. A quarter came in with critical limb ischemia and 3/4 with claudication. A third were treated with a surgical procedure and 2/3 with an endovascular hybrid approach. The median time from the intervention to randomization was 5 days. Now I'm showing you the primary endpoint in the placebo arm. As you can see, 19.9%, or roughly 1 in 5, experienced a component of the primary endpoint over the 3 years shown of follow-up. Risk was particularly steep in the first year, but continued over time. Now in the purple, I'm showing you the effect of randomized rivaroxaban. As you can see, the curves separate early by 3 months and separate over time. Overall, there was a statistically significant 15% reduction in the primary endpoint with rivaroxaban, with a p-value of 0.0085. Now, to put this relative risk reduction into context, given the absolute risk of the population, at 6 months, there was a 1.5% absolute risk reduction in a number needed to treat of 65. At 12 months, a 2% reduction in a number needed to treat of 50. And at 3 years, there was a 2.6% risk reduction in a number needed to treat of 39. Now, looking amongst the components of the primary endpoint, you see the composite at the top. You'll see acute limb ischemia was the most frequent adverse outcome in the placebo patients, as was feared, and there was a robust reduction with rivaroxaban. Overall, there was general consistency amongst all of the components of the primary endpoint, with the exception of cardiovascular death, where we did not see a benefit for rivaroxaban. In terms of secondary outcomes in the order of the testing hierarchy, you'll see that the first 5 secondary outcomes, all listed here in order, showed statistically significant reductions with absolute risk reductions of 2.5% or greater. That second set of bars is the particular concern for unplanned index limb revascularization during follow-up, and that was reduced by about 2.5% as an absolute risk reduction. And then on the fourth set of bars, when we lump in all-cause mortality, again, we see a significant reduction with an absolute risk reduction of about 2.6%. Mortality alone, there was no difference between the arms, and VTE had a hazard ratio of 0.61 and a nominal p-value due to its position in the hierarchy of 0.0469. When we look at key subgroups, we saw consistency generally across all of the major subgroups. I'll draw your attention to the bottom. There was consistent benefit in patients who presented with critical limb ischemia in spite of their very high risk, an event rate of about 24% at 3 years in the placebo arm. And there was consistent benefit in those treated with a surgical intervention as well as an endovascular intervention. In terms of safety, this is the principal safety outcome of TIMI major bleeding. There were higher rates of bleeding with rivaroxaban. The hazard ratio here was 1.43 with a p-value of 0.0695. This was an absolute risk increase of about 0.25% per year. In terms of the most feared safety outcomes, intracranial hemorrhage or fatal bleeding, there was no pattern for excess with rivaroxaban with either component, and actually numerically fewer for the composite, so no pattern of harm for these events. In terms of the other bleeding outcomes, you can see here, there were higher rates with rivaroxaban, and at the far right, ISTH major bleeding was increased with a hazard ratio of 1.42, a p-value of 0.0068, and an absolute risk increase of about 0.6% per year. In terms of safety, as with efficacy, we saw general consistency amongst the major subgroups for safety with higher rates of bleeding with rivaroxaban. Now, to put these results into context, in patients with PAD requiring revascularization, for 10,000 patients treated for 1 year with rivaroxaban 2.5 milligrams twice daily with aspirin versus aspirin alone, there'd be the prevention of 181 first ischemic events with the components listed below. The cost of this would be 29 TIMI major bleeds without any excess in intracranial hemorrhage or fatal bleeding. So in symptomatic peripheral artery disease after revascularization, in spite of background therapy, 1 in 5 have acute limb ischemia, major amputation of a vascular etiology, myocardial infarction, ischemic stroke, or cardiovascular death at 3 years. In this population and in this setting, rivaroxaban 2.5 milligrams twice daily with aspirin compared to aspirin alone significantly reduces this risk with benefits apparent early and continued over time, consistent benefit across major subgroups, including those with critical limb ischemia, and broad benefits, including reductions in the need for unplanned index limb revascularization. It does increase bleeding, and in Voyager PAD, there was a numerical increase in TIMI major bleeding and statistically significant increase in ISTH major bleeding, but no excess in intracranial or fatal bleeding. And putting them together, there is about a six-fold increase in the number of ischemic events prevented relative to bleeds caused. These results are now available online at the New England Journal of Medicine, and slides are available for download at the CPC Clinical Research website. Thank you.
Thank you very much, Dr. Bonaca, for a very, very interesting study and very pragmatic study. I'd like now to ask some of my colleagues to discuss the study. Dr. Beckman, what is your opinion?
Thank you very much, Dr. Fuster. And first, I would very much like to congratulate Dr. Bonaca and his co-investigators for this study. This, I think, really expands our understanding and of the value of rivaroxaban in patients with peripheral artery disease. I would like to make a couple of specific points. First, I am quite impressed with the fact that they have now expanded the concentric circles of PAD patients that are now likely to gain benefit from rivaroxaban. If we take a look at the COMPASS study, and even in the PAD specific patients of the COMPASS study, this was primarily a polyvascular disease patient population. We now know that in a PAD population without significant evidence of polyvascular disease, rivaroxaban also provides a significant benefit. Moreover, I think this points quite clearly to the point in time of care when this medication can be applied, and to a specific population of treating clinicians. The application of these therapies after either endovascular or surgical revascularization is a perfect point in time to begin. Patients who are treated with medications beginning in the hospital are more likely to take them a year later, and this gives us a specific place to do that. Another point I'd like to make is that this, I think, really brings acute limb ischemia to the cardiovascular treating community. Many of us who participate in vascular care see this routinely and understand it for the really severe event that it is. But I think this will make it even clearer now to those of us who are specifically in cardiovascular medicine and being able to understand its impact as well as our vascular surgical colleagues. ALI is a severe event that comes with a significant amount of morbidity and mortality, and it's something to be feared and avoided as much as possible. I was very happy to see that the medication provided benefits that were similar across the range of symptomatic severity from claudication to CLI. Also that it was similarly beneficial in the surgical and endovascular patients, such that we don't have to consider choosing to apply this therapy or the method of revascularization to gain the benefit. I think that this study advances our understanding of where to use rivaroxaban. It expands the concentric circle to now include a PAD population that I think was relatively under-tested in COMPASS. And I think it's going to be very helpful for our interventional colleagues, both medical, surgical, and radiological, to be able to apply a therapy that may make them better as interventionists, because it's going to reduce the number of times they have to go back and fix their earlier work. So with that, again, I want to apply my congratulations. I think it's an incredible trial, and I think it's going to advance the methods of our care and our patients' benefit. Thanks very much.
Thank you very much, Dr. Beckman, for your excellent comments. It's interesting that these new oral anticoagulants are now coming into the field of atherosclerotic disease, native, non-native, after intervention, and so forth. And this is a very interesting study in this regard. I'd like to ask my colleague and friend, Dr. Pat O'Gara, what is your opinion, Pat?
Oh, thanks very much, Valentin, and my congratulations, Mark, to you and Dr. Hyatt and your co-investigators for a very well designed, executed, and reported study. I just have a few questions, and in the spirit of some interactivity with the presenter, Mark, I'm going to give you a couple of questions, and then perhaps you could respond to those with your concluding remarks. The first would be that I was a little surprised that the prevalence of coronary heart disease was so low among your patients who presented for a symptomatic lower extremity peripheral arterial disease requiring revascularization. That seems to be somewhat at odds with the typical phenotype of the patient seen in clinical practice. My second question really has to do with whether or not you were actually surprised that the sole driver of the difference in outcomes between the two groups was related to acute limb ischemia. Were you expecting to see any improvement with respect to myocardial infarction and stroke risk reduction in this patient population? And if not, why not?
Great. Well, thank you, Pat, for those questions. Are you able to hear me?
Yes.
Okay. So for the first question, I think this is an incredibly important question. I think that there is the notion that atherosclerosis is a systemic disease. And so if you have it in the legs, you have it everywhere. And it is true that many patients with PAD have coronary disease. But the truth is, if you're selecting patients based on hemodynamic occlusions in lower extremity, the proportions we saw in this trial are actually consistent with others. If you look at the Euclid trial, 30% had coronary disease, 10% had myocardial infarction, almost exactly the same as this population. And I think the issue from a trialist perspective is the majority of data we have in PAD is subgroups of coronary trials, where coronary disease is, of course, very common because that's the reason they're in the trial. And we have very few dedicated PAD trials. But I think for the vascular practitioner doing intervention, they're seeing a lot of patients with symptomatic PAD that don't have known coronary disease. And this probably reflects that population in a very distinct fashion. And that really brings us to the next question, which is the components of the primary outcome. I personally was not surprised to see that the benefit was driven by acute limb ischemia. You know, we see consistency in terms of the point estimates, but the trial is not powered for any of the individual components. And with 5 components, we're not going to see statistically significant differences in the individual components. And we saw consistency for stroke and MI as we expected, with point estimates quite consistent with the overall. But that being said, this is what happens to these patients in this setting. They have bad limb events, and they are thrombotically mediated, and that's what we saw reduced in the trial. So I think this really tells us both about what the drug does, but more importantly about the natural history of this population. Thank you.